recognize the member for Hamilton Centre.
Thank you very much. Thank you, Speaker. It's my pleasure to speak on the Primary Care Act. As a family doctor, anytime I hear of an initiative to try to expand access to team-based primary care, it's incredibly exciting. We know that, in Ontario, we have a crisis in terms of the availability of family doctors. And so any effort to try to address that is very laudable, and I appreciate seeing this bill. And, as an NDP caucus, we believe that everyone in Canada should have access to an interdisciplinary primary care team. And expanding access to this model of care will ensure that patients receive the right care at the right time from the right healthcare professional. We know that primary care is the foundation of a high-functioning health system, and data from around the world shows that team-based models of primary care have lower costs, improve access to the most appropriate types of services, and reduce inequities in a population's overall health status, including making sure that populations such as First Nations and rural populations have access to exceptional qualities of care. We also know that having more family doctors in the community has been proven to actually increase life expectancy by ensuring that people have access to preventative care and earlier intervention for disease. And all Ontarians deserve to be able to experience that benefit. And yet 1.7 million people across Ontario lack a family doctor. And we know that there are significant disparities in access to primary care based on geography and income status in our province. And while approximately 12% of the highest income residents are without a family doctor, that number actually increases to 20% when we look at our lowest income residents. So ensuring that when we talk about expanding team-based primary care, we are doing it intentionally to try to meet the needs of our less resourced people in our province is extraordinarily important. We also know that health human resource challenges are a key part of the problem that we face today. We know that family doctors have been retiring or burning out at high rates, with many choosing to leave primary care clinics for other forms of practice. And despite these challenges, Ontario has some examples of high-quality, comprehensive, team-based primary care that we can learn from. For example, family health teams in Ontario provide patients not only with a regular family doctor, but also access to other primary care experts like nurses, social workers, pharmacists, and physiotherapists who work together to improve health outcomes. Unfortunately, as it stands, only 20% of people in Ontario have access to such a model of care, leading many to turn to emergency departments or walk-in clinics when their needs are high. We know that integrated team-based care is the way forward, and it's laudable to see team-based primary care proposed as the vision for this province moving forward. We support the expansion of comprehensive team-based primary care. We believe that everyone in Ontario should have access to an interdisciplinary team of health professionals who are working to the top of their scope of practice, with team members reflecting the needs of the patient population served in each individual community. We know that family doctors, in partnership with healthcare professionals like nurses, nurse practitioners, social workers, and others, will constitute essential members of such a team. And we know that such a model has been shown to increase the number of patients that a primary care practitioner can take on, including family doctors and nurse practitioners, which improves patient outcomes, increases the joy at work for providers, and optimizes the scarce health human resources that we have. And with this model, patients can receive the right care at the right time from the right healthcare professional. To enhance access and delivery of team-based primary care, we need to think geographically, similar to public schools. So rather than relying on chance or personal connections to find a family doctor, relying on people's postal codes and neighborhoods, and ensuring that everyone knows that no matter where they go, they are going to be automatically connected to high-quality care. This gives patients the same reassurance and convenience of primary care close to home, similar to how children attend their neighborhood public school. Imagine how much comfort this would give to patients. And I would also say that I'm going to be sharing my time with the member from Nickel Belt today. And instead of the geographic system that I would propose, right now and in recent months, we've seen that with every new opening of a primary care practice, we see hundreds of people forming a line, desperate to try to access care, and people still unable to access care in their communities. We need to be able to deliver better care than that. A universal, accessible, and comprehensive approach is in keeping with the initial vision for Medicare in Canada. As Tommy Douglas envisioned universal health care, its first phase was the removal of financial barriers for those receiving care, a stage that was achieved for physician and hospital services already. However, this first phase of Medicare was meant only to be a prelude to a more comprehensive second phase that still remains to be realized. It encompassed a fundamental restructuring of healthcare delivery with a greater focus on illness prevention, health promotion, and the policies related to addressing the social determinants of health. Expanding access to comprehensive team-based primary care located in patients' communities is an important step to achieving that vision. The Primary Care Act, as proposed, sets out 6 clear objectives for Ontario's publicly funded primary care system to ensure that people know what they can expect when connecting to primary care. And as I've said, there are many things in this proposal that are a commendable vision, and certainly Dr. Jane Philpott is a visionary in primary care. The 6 clear objectives are to ensure that primary care is province-wide, that it's connected, that it's convenient, that it's inclusive, that it's empowered, and that it is responsive. And again, each of these 6 objectives on their own are good things that we should be working towards. But we need to ensure that this plan doesn't just include a broad vision or a dream, but also includes a roadmap as to how we get there and how we deliver on this promise for Ontarians. I would hope that as we see this move towards implementation, we see that roadmap, and rather than big ideas and promises, we ensure that this doesn't remain an empty promise, and we actually work to fulfill it. The Act also talks about providing accountability by ensuring an annual report is produced to demonstrate how many patients have been attached to team-based primary care and how many are still left unattached. And with any method of reporting and data collection, we must ensure that we are using the right data to measure the outcomes for our problem. And what concerns me about this is that in its recent primary care funding call to expand team-based primary care, our province identified postal codes at highest need based on Healthcare Connect data. And for those who might not know, Healthcare Connect is quite an old system used to register patients who are unattached and attempt to connect them to care. But what's happened in recent years is because it became such an obsolete, cumbersome system, many regions are not actually using the Healthcare Connect system to register unattached patients. And so what we saw in feedback from this recent funding call was that if we're relying on old, outdated data, many unattached patients are going to be missed. We're going to think that we're doing better than we are, and we're going to lose the opportunity to actually direct resources to places in greatest need. And so I think we should respond to that community feedback by ensuring that as we work towards this accountability in these annual reports, we are also working towards garnering data that is going to better reflect the scope of the unattached patients in our province so that we can better direct the resources where they need them. This is something that I would like to see addressed in the next iteration of funding calls for expanded care, including the one we expect in this fall as per the Minister of Health. And we can't talk about expanding province-wide primary care and ensuring more connected, convenient, and responsive care without talking about the healthcare professionals who will be delivering that care, particularly family doctors, nurse practitioners, and interprofessional health disciplines working in a team-based model. Family doctors practice one of the most complex specialties with the most enormous scope. We are trained to see anyone for any concern and be able to appropriately assess, diagnose, treat, and identify any necessary investigations or referrals to specialist care. And I'd like to walk you through what a day of an average family doctor looks like in practice so we can better understand how we might actually support them in expanding their care for their communities. So as a family doctor in a fairly standard community clinic, you might start your day with 24 or more patients booked, with room for a few more to be squeezed in who have urgent issues that require same-day attention. In the first room that you walk into, you might be seeing a newborn just home from the hospital. You'll complete a thorough newborn exam, provide counseling to the parents on safe sleeping, on feeding, and reassure them that they're doing a good job and that their baby is going to be just fine. 15 minutes later, you'll enter your next patient room. It's a 58-year-old man who was squeezed in your schedule today because he's been having a pressure sensation in his chest since last night that just seems to be getting worse. As you examine him, the most likely diagnosis becomes a myocardial infarction or a heart attack. And so you and your team quickly work to stabilize him, administer aspirin and nitroglycerin spray, call emergency services to transfer him to the emergency department, and because you know this patient better than anyone else, you'll call the emergency physician ahead of time to make sure that they know your patient is coming, that they know his history, and that they know how to best meet his needs. But because you've done all that, now you're 20 minutes behind. Your next patient is a 28-year-old construction worker who is injured on the job and needs a WSIB form filled. You take time to ensure the forms are filled correctly because you understand how burdensome it is for claims to be rejected on the basis of bad paperwork. You move on to the next room. It's a parent and their 14-year-old child who has been struggling with depression and anxiety. They booked the appointment today because of worsening self-harm and suicidal thoughts. They're out of school now and the whole family is struggling. The parents are terrified to leave the child at home. You do everything you can, treating their symptoms with medication, offering take-home strategies and cognitive behavioral therapy workbooks, and connecting them with counseling and social work. You'll call them in a couple days to see how things are going and make sure everyone is feeling okay. You promise to check on that referral for child psychiatry again, but you know all too well that the waitlist is 18 months, and you'll have to see this patient for many more visits to try to carry this family through the next few months before they actually get there. Then you'll see a pregnant patient for prenatal care, then a diabetes checkup, then a skin biopsy for potential cancer, then strep throat, then maybe a few others for chronic pain. Your final patient of the morning is an elderly couple, an 88-year-old man with cognitive impairment and his wife. His wife tells you that his dementia is getting worse. He's starting to leave the house and got lost last week. He's looking for the car keys even though he's not allowed to drive. And more his memory changes are giving way to an increased mood lability and outbursts. They haven't noticed much change with the medication, and it's becoming increasingly difficult to cope at home. Your patient's wife is now struggling. She's not sleeping, she's not eating. She's trying to be a nurse, a PSW, and a wife all in one while waiting on the long-term care wait lists that we know can be 2 or more years long. Over lunch, you catch up on phone calls that have come in, patients who want to speak with you, pharmacists that need med clarification, a request for a home visit for your palliative care patient trying to live out their final days in the comfort of their home. You've also accumulated by this time about 50 pieces of admin work, x-ray results to review, blood work, specialist reports, forms, med checks. You try to chip away at those too. And then the afternoon starts in another round of a dozen or more patients with any number of concerns and areas of attention, and each one needs your 100% care and attention in that moment. And by the end of the day, after you've seen all of your patients and you've done what you can, you're left with on average 3 to 4 hours of charting and documentation, forms, medication renewals, and administrative work that needs doing. And luckily, it's a day that you're not on call, so you're able to stay late and get it done into the evening. And on top of all of this, many family doctors are also responsible for billing each and every patient visit and ensuring that from those OHIP billings, they're able to pay their staff, pay their rent, pay their supplies and their other business costs. And most family doctors don't want to have to do all that. They don't want to be small business owners. They just want to be clinical experts. They want to provide care. Trying to do both is just not sustainable, and it's not what they're trained for. And that's what we're seeing with most family doctors entering practice today, is they don't want to be small business owners. They just want to be clinicians providing the care that they can to their patients. They're asking for alternative funding models to support them in delivering that care to the communities that they need it. We know that family doctors provide an incredible service to their patients, and as I've demonstrated, when practicing at full scope, they can provide a vast array of essential services to their patients. We can't take that for granted. And in addition to the office-based clinical care, many family doctors also provide obstetrical care, cover emergency department shifts, hospitalist shifts, do surgical assist work, or take on any number of other tasks in the community, like caring for people in long-term care. Our family doctors are holding up our health system, but we need to take care of them just like they're taking care of the people of Ontario. And to do that, we need to commit to making a few very substantial improvements to our primary care system. And because I care about this so much, I'm going to offer to you some advice from the many conversations I've had with family doctors about what would actually make a career in family medicine sustainable for them and what would help you realize the dream of this Primary Care Act that you've put forward. So first and foremost, we need to move away from business entrepreneurship models and fee-for-service practices and transition every doctor to capitation, alternative funding models, or salaried positions that provide more reliable compensation without the additional stress and workload of running a small business. These positions already exist in family health teams and community health centers, but we need to expand them and bring all family doctors into those funding models so that we end a system of haves and have-nots within primary care. We also need to compensate family doctors for indirect primary care. So right now, and indirect primary care, for those who might not know, is basically anything that you do to care for your patient that doesn't include you sitting in front of them. And so right now, family doctors are only compensated for the exact amount of time that they are sitting with their patients. But we know that providing care includes much more than that. Indirect patient care includes the time it takes to send specialist referrals, to review blood work and test results, to complete forms, to arrange home care, to send prescriptions, and much more. And as it stands now, almost all of that work is unpaid labor. It also takes a huge amount of time. So the average family doctor reports that administrative work takes up to 20 hours a week. So that's like adding a part-time job onto your full-time job, and it contributes to burnout. And that's why in a recent Ontario Medical Association survey, administrative burden was one of the main reasons why physicians were choosing to retire or transition out of full-scope primary care. And in other provinces, there are models that we can learn from, so we don't have to reinvent the wheel. In British Columbia, the longitudinal family physician payment model was launched in 2023, and this model compensates family physicians with an hourly rate for indirect patient care services. It recognizes that the work they are doing, even when they're not sitting with a patient, is still work in service of their patients and has value. It recognizes the value of the work that family physicians are putting in every day and also makes the work more financially sustainable for doctors considering their career choices. This is something that we could work to implement to model after our colleagues in BC who have already seen the benefits. But I haven't seen this mentioned in any of the primary care funding models that our government has put out this far. I hope that this is something we can expect in the incoming funding as it comes along later this year. And while providing compensation for essential indirect patient care, we also need to do what we can to actually reduce the administrative burden on family doctors, not just pay them for that extra part-time job. One thing that we could do is to create a streamlined, centralized referral process for specialist referrals. Our current system for specialist referrals is completely obsolete. So right now, if you wanted to refer your patient to a cardiologist in Hamilton, for example, you have to manually refer to an individual cardiologist in your region, and usually that happens by fax. Then you wait an average 2 to 6 weeks to hear back from that cardiologist about whether they can accept the referral or whether that referral is rejected. Then you have to send it to a different cardiologist in your region and wait another 2 to 6 weeks to hear if that one's going to take on your patient. And so on it goes. And usually you have to refer to several specialists before you find one that's actually accepting referrals. And every time this happens, it increases the burden back on the family physician, who's basically tossed the hot potato once again. And patients in the meantime are left waiting, getting increasingly frustrated, sometimes getting increasingly ill, and waiting for an answer as to when they're actually going to see their concern seen. By moving towards a centralized referral system, we could eliminate the administrative burden on each individual family doctor's office trying to navigate this referral system. By making a centralized or regional referral system, we could provide real-time updates on referral status, ensure that waitlists can be tracked regionally so we understand where the gaps are and where we need to direct specialist resources, and we could actually ensure that patients are seen in a more timely manner with expectations that can be met. This is what family doctors have been calling for, and it's something that we could easily implement that would offload administrative burden, streamline specialist access to care, and improve patient care outcomes. The other thing that we could do to eliminate administrative burden is to eliminate unnecessary paperwork. So, for example, we can start with sick notes. We need to clamp down on employers asking for sick notes from a healthcare provider. Most people who take a sick day don't need to be rushing in to see their doctor or trying to book a last-minute appointment. They just need a day of rest. And when we see patients trying to book in with their doctor to get a sick note that's unnecessary, that takes away an appointment spot from someone else who could really need it. Or it means that our family doctors are trying to squeeze an additional patients in their day just to write a note that wasn't necessary in the first place. This is something that we could legislate that would have both enormous benefit for workers while also reducing the burden on family doctors. And when we talk about eliminating unnecessary administrative burden, we also need to talk about meds checks forms. So we heard this week that Shoppers Drug Mart alone has billed $62 million in meds checks forms over a 14-month period. And for those who don't know what a meds check is, it's meant to be a pharmacist's review of medications to identify any contraindications, any need for medication monitoring, any medication flags that a family doctor should know about. Medication reviews were already standard practice for any good pharmacist, but what changed was that pharmacists are now able to bill for med checks even if it's just a 5-minute phone call. And when private companies like Shoppers got a hold of this tool, they became an avenue for profiteering. So we've now seen numerous pharmacists who have come out and say that Shoppers Drug Mart imposed corporate quotas on meds checks, forcing pharmacists and staff to cold call patients, fraudulently asking non-pharmacist staff to call patients to complete these meds checks and bill them, and doing med checks over the phone and billing $75 for 5 minutes of unnecessary work. It's a tremendous waste of money. But what happens to those med checks after Shoppers has made those $75 is that they get faxed to family doctors. And in my family practice, I would get dozens of med checks in my inbox every single day, each taking several minutes to review to make sure that there wasn't information there that I actually needed to know. And those minutes add up throughout the day, and it adds to the hours of admin work that you are already doing. And do you know how many meds checks $62 million can buy? 827,000. That's 827,000 pieces of administrative work that family doctors have had to review so that Shoppers Drug Mart can make a profit. And by the way, family doctors don't make a single dime for reviewing those med checks. Their labor is free. But because Shoppers Drug Mart wanted to exploit our system, we've increased the workload for our doctors. The Minister of Health said months ago that the meds check program would be investigated for any signs of corporate abuse. But we've heard nothing since then. And yesterday, when it was asked about in questioning, we also had no updates as to what the investigation in meds check has actually yielded. This would be a very concrete step the Ministry of Health could take to eliminate unnecessary administrative burden on family doctors, while also sending a message that corporate profiteering in our health system will not be tolerated. And lastly, to reduce administrative burden, we need to expand access to digital tools that can reduce the amount of time spent on administrative tasks. This can include transcription tools, open access electronic medical records, and working towards integrated electronic health systems that are province-wide and connect community care providers to hospital care providers more seamlessly. Digital tools could also ensure that all family health teams are supported with the technology to facilitate online appointment bookings and patient-centered communication tools. But we must improve access to these digital health technologies without imposing onerous reporting requirements that actually increase the administrative burden for family health teams. And lastly, we need to ensure that all family doctors are able to join team-based primary care. We need to ensure that the team-based primary care model is an open invitation for any practicing family doctor to be able to join. And that is something that in this bill I find very commendable. The commitment to moving towards team-based primary care province-wide is a very important one. And as I've said, Dr. Philpott is certainly an extraordinary leader, and I'm glad to see that her advice is being listened to. But in order to realize the vision of province-wide team-based primary care, we also need to pay attention to the details and ensure that we get the implementation right. In addition to addressing compensation for family doctors, we must also ensure that the wages of community-based allied healthcare, including nursing, are fair and commensurate with the value of the work they are delivering in our communities every day. One of the main criticisms of the province's primary care funding call that just went out was that while it offers to fund more interprofessional health team members, it does not address the issue of low wages and low retention rates of those same allied health team members. And as it is, many family health teams are struggling to retain their staff because of the low wage levels set by the ministry. Community nurses are already paid markedly less than nurses in hospital, and we see more and more nurses leaving the public sector to work in private agency nursing, and then those private agencies gouge our health system by charging a premium. So if we want to expand team-based primary care, we need to ensure that our teams are well compensated, including nurses, physiotherapists, systems navigators, social workers, mental health counselors, administrators, and others. We won't be able to realize the dream of expanded team-based primary care without investing in our actual teams. The other thing that this Primary Care Act is missing is a province-wide coordinated physician recruitment strategy. And despite the challenges in recruiting and retaining family doctors in nearly every municipality across Ontario, our province has yet to put forward a comprehensive physician recruitment strategy to actually offload the burden from our municipalities. As a result, we see municipalities trying to cobble together financial incentives and other benefits to try to recruit family doctors to their region. In some cases, this means some municipalities are able to offer hundreds of thousands of dollars from municipal budgets to direct to family doctors as recruitment bonuses or to offload startup costs. For many new graduates leaving family medicine residency with hundreds of thousands of school debt, this is a major factor in determining where to set down roots and start the career. But the result is that some municipalities are disadvantaged compared to others. For example, in some municipalities like London, there are no financial incentives to recruit family doctors to the region, and as a result, there is a tremendous deficit and a high number of unattached patients in London compared to other regions. In other municipalities, physicians might be offered $200,000 or rent-free office space to set up a practice. With this kind of discrepancy across the province, we can see how the absence of a province-directed strategy is creating haves and have-nots municipalities across the Ontario. It also means that municipal funds are being used to supplement what should be a provincial responsibility of ensuring that we have an equitable distribution of health professionals across Ontario. We could address this with a comprehensive province-wide strategy for physician recruitment. A good strategy would include the province setting a standard and footing the bill for financial incentives and debt repayment for new family doctors setting up a full-scope family practice in Ontario. As part of this strategy, the province could identify areas across Ontario that are underserved, that have the highest number of unattached patients, and adjust financial incentives to support targeted recruitment to those areas in greatest need. It would be a win-win, because municipalities would be able to use their budgets for items that are actually within their mandate, and our province would be able to fill the promise of an equitable access to primary care across Ontario. Without a province-wide strategy, we will continue to see what the OMA has described as a rat race in physician recruitment. We need to be strategic, and in this bill, we have an opportunity to think about how we could implement a comprehensive recruitment plan province-wide now. We also know that as it is, we have a dire shortage of family doctors, with 2.5 million Ontarians lacking a family physician. We know that with anticipated retirements, the number of Ontarians without a family doctor is projected to increase to 4.4 million in 2026. And for context, that would be about 1 in 4 Ontarians lacking a family doctor. While this bill does not address physician recruitment or retention, we know that in order to realize the vision of team-based primary care, we need to have enough family doctors to staff them. We've heard a lot about potential strategies to increase the number of family doctors that we have, including reducing barriers for international medical graduates and licensed physicians from other countries who are new to Canada. And I agree that these are important areas to examine and that we could do much more to recertify internationally trained health professionals in our province. But the lowest barrier, low-cost strategy that we have is ensuring that every physician that we train in Ontario actually chooses to stay in full-scope family medicine in Ontario. And even further, we need to ensure that we create sustainable work conditions so that all family doctors we currently have practicing are able to continue practicing for the full duration of their career. And if we could only accomplish those two things, we would be able to enhance our family medicine workforce substantially without spending a single dollar on advertisement or recruitment campaigns in other provinces or in other countries. It would be a great place for us to start. Last year, we saw 246 family medicine residency spots go unmatched in the first round. That number was reduced to 94 spots by the second round, indicating that we were able to fill some spots largely by opening up to international medical graduates. But 94 spots is still far too many. And if we invest in expanding the number of primary care teaching sites and residency spots, we need to ensure that we're actually able to fill them. Each year, I supervise dozens of family medicine residents and medical students, and we talk about where they see themselves going in their careers. Many of them entered into medical school with the dream of becoming a family doctor and serving their communities. But that dream has become eroded over time by the hidden curriculum that tells students and trainees that family doctors have become a dumping ground in an overburdened medical system. They look to their family supervisors as models, and they're inspired by the incredible clinicians that they see taking on family medicine education as well as providing exceptional care to their patients. They see the great impact that a family doctor can have on their patients, their communities, and they want to emulate that. But they also see those same supervising doctors staying hours late, catching up on paperwork. And in the teaching practice where I worked, it was common for all of us supervising physicians to still be in the clinic at 9 p.m. at night, sitting alongside each other, catching up on paperwork and on calls. Our residents and our medical students were watching us, and they were asking whether or not this was the career that they wanted for themselves. Recruiting Ontario-trained family doctors into full-scope family medicine should be our top priority. We've already paid for their training, they are already certified, so it's a low-cost, high-yield intervention to enhance our family medicine workforce. Expanding team-based care is a great place to start, but we need to ensure that the working conditions for the family doctors in those teams are actually sustainable. And many of the system changes I've already described would help achieve this. And as I've said, there's many laudable components of the Primary Care Act, but there's one word that is repeated over and over and over throughout the legislation, and that word is ensured. It's mentioned over and over again that the promise of equitable access to convenient, patient-centered primary care is a promise only offered to those who are insured in our province. But we know that there are hundreds of thousands of people in Ontario who are uninsured and have no access to primary care or other health services. And many of those who are uninsured are newcomers or migrants in Canada who we know face additional barriers to accessing care when they need it. And when we don't provide health coverage, we know what happens. People are unable to access early preventative or interventional care, and we end up seeing them in hospital only when they're critically ill and needing much more expensive services. Or our healthcare providers in our hospitals are put in the terrible position of handing a sick person a bill and seeing if they can get it paid. And often those bills aren't able to be paid, leaving our healthcare providers and our hospitals losing money for services rendered. In 2020, our province implemented the Temporary Physician and Hospital Services for Uninsured Persons program. And I'll give a compliment when a compliment is due. I think that was a very good program, and that was a great step. This was part of our pandemic response and allowed physicians and hospitals to directly bill the government for uninsured services offered to people who lacked coverage. The temporary funding for uninsured persons was in place until March 2023, and over those 3 years, 7,000 physicians billed 400,000 services under the program, costing only $15 million. For $5 million a year, we are able to address a gap in uninsured services that we have been struggling with for decades. It was so cost-effective. And $5 million a year is just 8% of what Shoppers Drug Mart billed us for med checks last year. And somehow we're able to find that money. It's staggering to think that our government would consider that a more worthy investment than ensuring health for all and offering access to health care for every single person in our province. We need a true universal health system, and reinstating funding for physician and hospital services for uninsured persons would be a substantial and commendable step in realizing that promise. And on that note, while the Primary Care Act sets out very laudable goals and a vision for province-wide primary care that is publicly funded, it stops short of affirming whether or not that care will be publicly delivered. We have seen time and time again how opening up our public healthcare dollars to private corporations has led to abuse and exploitation. We cannot continue to bleed money into the private sector while our hospitals and community clinics see cuts and budget freezes. We need to ensure that all public healthcare dollars are invested in publicly delivered services that improve care for all Ontarians. I would hope that our government would commit that every dollar of taxpayers' money spent on expanding team-based primary care will be invested in publicly funded, publicly delivered health care. And as I've said, there are many good things to work with in this Primary Care Act. There is a good vision for team-based primary care, but if we don't pay attention to the details and implementation, we are at risk of failing to meet that promise, of losing money to the private sector, and of leaving people behind. Thank you, Madam Speaker.